So imagine looking at a fetal ultrasound.
Wow.
You see this perfectly formed little hand, except, well, it looks like the fingers are wearing a permanent mitten.
Yeah, and for about 1 in every 2,000 live births, that mitten just doesn't go away.
Exactly. So today we are dissecting the exact cellular missteps and, the mechanical failures that cause congenital upper limb anomalies, specifically focusing on soft tissue failures of differentiation.
Welcome to this revision deep dive. We're two plastic surgeons, and we are speaking directly to you, the resident preparing for your board exams, like the FRCS in plastic surgery.
Yeah, we know your time is incredibly tight, so we're using a strict, high-yield question and explanation format to break down exactly what you need to master. No fluff.
Right, none at all. But before we jump into the pathophysiology, press follow right now to catch all our upcoming revision deep dives.
And if you actually learned something valuable from our discussion today, please rate the show.
Also, to really take your revision to the next level, get a premium subscription to listen to our journal club and clinical cases deep dives.
Absolutely. So let's strip away the noise and focus purely on the facts, the pathophysiology, and the surgical principles. Let's get to work.
Sounds good.
Let's start with that permanent mitten we mentioned, syndactyly. I mean, it's the baseline, right? The most common soft tissue failure you'll encounter.
It really is.
So walk us through the high-yield epidemiology and what's actually going wrong at a cellular level. And as we get into this, I always like to clarify something right up front because residents constantly mix up the pathogenesis of standard syndactyly with acrosyndactyly.
Oh, all the time.
Right. So think of regular syndactyly like two pieces of fabric where the manufacturer just simply forgot to cut the seam.
I like that.
But acrosyndactyly is like a jacket zipper that got completely mangled and melted together at the top, leaving those little holes intact at the bottom.
Yeah, the mangled zipper is the perfect way to visualize it. Conceptually, it explains why you still see those little holes or fenestrations at the base of the fingers. But let's start with standard syndactyly. The term comes from Greek, syndining meaning together, and dactylos meaning digit. And the root pathogenesis here is a failure of apoptosis.
Which is just programmed cell death.
Right. During embryonic development, the hand initially forms as this solid paddle. Normally, the tissue between what will eventually become the fingers undergoes apoptosis.
The cells basically self-destruct on cue.
Exactly. They self-destruct to create the web spaces.
Mm-hmm.
When that biological signal fails, the fingers just remain tethered together. So like you said, the manufacturer forgot to cut the seam.
Okay, so what are the absolute must-know statistical numbers for the boards here?
Well, it occurs in 1 out of every 2,000 live births. It's actually tied with polydactyly as the most common upper limb malformation.
Wow. Yeah.
You also need to memorize that 20% of cases have an autosomal dominant family history, and 50% of cases are bilateral.
50%. And what about demographics?
It's twice as common in males as in females, and statistically it's most common in Caucasian populations.
Got it.
Also, definitely be on the lookout in your clinical vignettes for associations with other conditions. You're primarily looking for Apert's and Poland syndromes.
Okay, so we know who gets it and why it happens structurally, but how do we classify it when a patient is actually sitting in the clinic?
So the classification system is highly testable because it directly dictates your surgical approach. We basically evaluate two things.
The extent and the tissue type.
Exactly. For extent, complete syndactyly means the digits are fused all the way up to the level of the fingertips. Incomplete means the fusion stops somewhere before the tips.
Makes sense. And the tissue.
And then we look at the tissue. Syndactyly involves only soft tissue connections, so just skin and fascia between the digits. Complex means you have both soft tissue and actual bony connections.
So the bones are actually fused together in that case?
Yes, you have a synostosis. And finally, there is complex, complicated syndactyly.
Which sounds like a nightmare.
It is. This implies there are associated accessory digits or abnormally shaped extraphalanges hidden within that syndactyly web. The anatomy inside that web is highly unpredictable.
Which brings us back to that mangled zipper, acrosyndactyly.
Right.
How does the mechanism differ from the apoptosis failure we just outlined?
The pathogenesis is entirely different. In acrosyndactyly, the distal parts of the digits actually separated normally early in embryonic development.
But then they refused later.
Exactly. This is caused by constriction ring syndrome. Basically, amniotic bands wrap tightly around the developing digits in utero, causing local tissue necrosis.
Oh, wow.
Yeah, and as the tips heal from that ischemic injury, they melt and fuse together. That's why you always have those small spaces or fenestrations proximally. The base separated perfectly fine, but the tips melted together afterward.
That distinction makes so much sense when you picture the timeline of embryology. So let's move from the cellular level to the physical exam. Where does standard syndactyly actually show up most frequently on the hand?
The middle ring finger web is by far the most commonly affected. That accounts for 58% of cases.
Okay, middle ring is number one.
Right. Next is the ring little finger web at 27%. Then the middle index web at 14%. And finally, the thumb index web is the rarest, sitting at just 1%.
Okay, let me throw a clinical vignette scenario at you. You're examining a child's hand. You notice nail fusion, so synonychia, and a complete loss of the peronychial fold on the lateral edges of the nail. What is the underlying anatomy doing?
Well, that physical finding is a massive clue. Synonychia combined with the loss of the peronychial fold strongly indicates a synostosis of the distal phalanges.
So it's a dead giveaway for a complex syndactyly.
Exactly. It's a key indicator. And functionally, it tells you that you aren't just dealing with a simple skin bridge. Complex syndactyly is heavily associated with underlying tendon, nerve, and vascular anomalies.
Right, which brings up the most common question parents ask during a consultation. Why can't we just separate all the fingers at once and save my child from multiple surgeries?
It's completely understandable why they ask that.
Of course. But for a resident planning the surgical timeline, what is the standard rule? And what is the absolute board exam exception where we are forced to rush?
So, the standard rule is patience. Surgical correction is usually not performed before 1 year of age, largely due to the anesthetic risks in infants, plus the technical difficulty of operating on such microscopic structures.
And we want it done by school age, right?
Right. The goal is to have the separation completed by school age to aid in fine motor development. But the major exception, and the one they will definitively test you on, is syndactyly of the thumb index or the little ring fingers.
Because of the uneven growth vector.
Exactly. Think about the massive length difference between the thumb and the index finger, or the ring and the little finger. These specific webs connect digits with significantly different longitudinal growth rates.
So they pull on each other.
Precisely. If you leave a rapidly growing index finger tethered to a shorter thumb, that length discrepancy acts like a tight bowstring. It will cause a severe, permanent angular bone deformity and joint deviation as the child grows.
Right, so we are forced to operate early to outpace the skeletal growth deformity.
Exactly. Therefore, these specific web spaces must be released early, often by 6 months of age, as soon as the child is deemed medically fit.
Okay, so walk us through the staging principles when we actually do operate. What are the anatomical landmines?
The most dangerous landmine is vascular compromise. The golden rule is that you never ever release both sides of a single digit at the same time.
Because you'd basically be isolating its entire blood supply.
Exactly. You risk cutting off the blood supply from both digital arteries, leading to ischemic necrosis and total loss of the finger.
Which is a disaster.
A total disaster.
Yeah.
So if multiple adjacent digits are involved, surgery must be strictly staged. In stage 1, you might release the thumb index and the middle ring fingers.
Leaving the index and ring fingers with an intact blood supply on one side.
Exactly. Then, you wait at least 3 months for the local tissue and vascularity to fully recover. Only then, in stage 2, do you go back and release the index middle and the ring little fingers.
Got it. And what about recreating the actual web space? What's the geometric goal we're aiming for?
So a normal web space isn't just a flat U shape. It normally slopes 45 degrees from dorsal to palmar, and it runs from the metacarpal heads to the midpoint of the proximal phalanx.
And recreating that slope is crucial for normal finger abduction.
Very crucial, yeah.
But when we get in there, the internal anatomy isn't always playing by the textbook rules, is it? I mean, the digital neurovascular bundle can be a massive headache.
Oh, it's a critical surgical hazard.
Yeah.
Normally, the common digital vessels bifurcate proximal to the web space. But in syndactyly, that bifurcation can frequently be situated distal to the position of your new reconstructed web space.
So what do you do?
If you encounter this anomalous anatomy, your web release is strictly limited to the level of that abnormal bifurcation. You have to stop your proximal dissection right there.
Even if it means leaving a shallower web space than you originally planned.
Exactly.
Wait, are there any exceptions where you can safely divide it?
You can only divide that bifurcation if one of 3 strict conditions is met.
Okay, what are they?
1, the other side of the finger is definitely not being operated on. That means you know its other digital artery is completely intact, allowing you to safely ligate the anomalous side.
Right.
2, you have definitively identified a second robust digital artery supplying that finger intraoperatively. Or 3, You're prepared to use vein grafts to essentially lengthen the artery and drop the bifurcation down proximally.
That makes sense. And what about the nerve?
The common digital nerve also frequently bifurcates distally, but unlike the artery, you can usually tease the nerve fascicles apart safely via interfascicular dissection.
Good to know. Let's talk skin coverage, the incisions and the flaps.
So rule number 1 of hand surgery: never use linear incisions along the axis of the finger.
Because a linear scar crossing a joint will inevitably contract.
Exactly. It causes a severe flexion deformity as the child grows. You must break up the scar line. We reconstruct the deep web itself using proximally based dorsal or volar flaps.
And why not just throw a simple skin graft into the very bottom of the web space? It seems easier.
Because skin grafts inherently contract. If you put a graft in the commissure, you get a phenomenon called web creep.
Where the scar contraction slowly pulls the web space distally over time.
Exactly, effectively retethering the fingers. You must use local flaps for the deep web. Defect closure along the lateral borders of the digits is achieved with dorsal and volar interdigitating zigzag flaps.
And we often have to supplement those flaps with full-thickness skin grafts for the residual raw areas, right?
Yes, very often.
Yeah.
And for those lateral nail folds we discussed earlier, you reconstruct them using hyponychial interdigitating flaps, familiarly described by Buck Ramko.
Perfect. That thoroughly covers failures of separation.
Let's pivot.
We've talked about what happens when fingers are fused laterally, but what happens when the soft tissues in the finger pull it into a flexed longitudinal curve?
Camptodactyly.
Right. The word literally translates to bent finger. We are talking about a progressive flexion deformity of the proximal interphalangeal joint, the PIPJ.
It mostly affects the little finger. It's often bilateral, and it has a prevalence of less than 1%.
Yes, so we are moving from lateral separation issues to volar tethering issues.
Right.
And if I'm examining a toddler versus a preteen girl, I have to figure out exactly what is pulling that joint down. How do we differentiate the root cause clinically? Explain the mechanics between intrinsic and extrinsic tethering.
Well, the pathology of Camptodactyly is really broad. Think of the volar aspect of the finger as a complex pulley system. Virtually anything crossing that volar surface can become tight and cause this bend.
Like skin, fascia?
Yeah, tight skin, fascia, the flexor tendon sheath itself. But it is most commonly due to an anomalous lumbrical muscle insertion or short flexor digitorum superficialis tendon, the FDS.
How do you isolate that exact cause on a physical exam?
You use a specific dynamic maneuver. You examine the patient's ability to passively extend the PIPJ while you alternately flex and extend their metacarpophalangeal joint, the MCPJ.
Okay, so what am I looking for?
If the PIPJ extension improves when you flex the MCPJ, it points to an extrinsic cause, like a tight FDS tendon originating further up in the forearm.
Oh, because by flexing the MCPJ, you're putting slack on that long extrinsic tendon, which lets the PIPJ straighten out.
Exactly. Conversely, if the PIPJ contracture remains exactly the same, regardless of what you do to the MCPJ, you're likely dealing with an intrinsic cause right at the joint level.
What if a board vignette throws an X-ray at you showing structural bone and joint abnormalities at the PIPJ?
Do not be fooled into thinking that's the primary cause.
Yeah.
Those bone and joint abnormalities are almost always secondary changes.
From the chronic flexion.
Yes. The chronic flexion posture puts abnormal pressure on the growing cartilage, physically remodeling the bone over time. The soft tissue tethering is the primary culprit.
So how does this present chronologically? You mentioned toddlers and preteens.
We classify it into 3 types. Type I is the most common. It presents during infancy, usually affecting just the little finger. Importantly, most of these cases are mild and do not require any treatment.
Good. And type 2?
Type 2 presents during pre-adolescence, roughly ages 7 to 11. It affects girls more than boys, and unlike type 1, it often progresses to a severe, rigid deformity during growth spurts.
And type 3?
Type 3 is a severe multi-digit form associated with various broad congenital syndromes.
Okay, let's say we have a progressing type 2 case. Function is rarely severely affected. Patients are usually seeking treatment for appearance or to avoid getting the bent finger caught on clothing. When do we actually operate, and what are we doing?
Surgery is notoriously difficult and unpredictable for Camptodactyly. The vast majority of cases with contractures less than 40 degrees are treated conservatively.
So stretching, splinting, that sort of thing?
Exactly. Aggressive stretching exercises, dynamic splinting, and serial casting. You only consider surgery when conservative measures fail and the contracture is severe.
What are the radiological red flags that warn you a surgical correction is going to be a nightmare?
You look for 3 specific signs of secondary joint remodeling on the lateral X-ray. Narrowing of the joint space, a distinct indentation on the volar neck of the proximal phalanx, and a flattening of the condylar head of the proximal phalanx.
So if you see those, the joint itself is mechanically blocked.
Precisely.
And if surgery is absolutely indicated.
It's a stepwise approach. You explore and release the tethering structures, so skin, fascia, anomalous lumbricals. If it's a tight FDS, you might perform an FDS tendon transfer to the extensor mechanism to rebalance the mechanical forces.
And for the severe bone changes.
You might need an angulation osteotomy to change the arc of motion. And in the most severe rigid cases where the joint is completely destroyed, you salvage the finger with an arthrodesis, basically permanently fusing it in a more functional position.
Let's stay with flexion deformities, but shift our focus. The thumb has its own unique architecture and its own unique ways of getting locked in flexion.
Absolutely.
I want to contrast two highly testable conditions that look similar at a glance but are vastly different. Here is a classic trick question on the boards. Congenital trigger thumb is a misnomer, isn't it?
Oh, completely.
Why is it a misnomer, and how does a resident rapidly differentiate a trigger thumb from a clasp thumb in a clinical vignette?
Well, it is absolutely a misnomer on 2 fronts. First, congenital trigger thumb is virtually never found in newborns. It develops postnatally as the child grows.
Right.
The prevalence hits about 3 per 1,000 around 1 year of age, and it's bilateral in up to 30% of cases. The second reason it's a misnomer is that the pediatric thumb doesn't actually trigger or snap back and forth like it does in adults.
So what does it do?
In kids, the interphalangeal joint is typically just rigidly fixed in flexion.
And what physical exam finding is the smoking gun here?
Not as nodule. It is pathognomonic and always present. As you palpate along the flexor pollicis longus tendon, the FPL, you will feel a distinct, firm nodule just proximal to the A1 pulley at the MCPJ flexion crease.
So the tendon has developed a localized thickening that simply cannot glide through the tight pulley tunnel.
Exactly.
So we have a fixed flex thumb with a palpable nodule. What's the treatment algorithm? Do we cut the pulley immediately?
No, we don't. Under 1 year of age, observation is the gold standard because up to 30% of these will resolve spontaneously as the child's anatomy grows and stretches.
Oh, that's high.
Yeah. And crucially, and this is the pearl for the boards, permanent joint contractures do not occur if you delay surgical release until age 3. So you have a very safe window to wait.
And when surgery is finally performed?
It's a straightforward longitudinal division and release of the A1 pulley to let that nodule glide freely.
Now, contrast that entirely with clasped thumb. If trigger thumb is just a tight pulley, what is clasped thumb?
Clasped thumb is a much deeper structural problem. It is a spectrum of severe abnormalities that cause the entire thumb to collapse into the palm.
Like what kind of abnormalities?
It ranges from a hypoplastic or completely deficient extensor mechanism to weakness in the thenar muscles to severe deep fascial contractures of the first web space.
So because the extensors are too weak to pull the thumb out, the flexors just overpower it and it stays tightly clasped in the palm.
Exactly. It's also frequently associated with broader syndromic conditions like arthrogyroposis.
I've always found it fascinating that the diagnosis for clasped thumb is so often delayed by pediatricians.
Well, it's delayed because it mimics normal neonatal behavior. Normal infants naturally hold their thumbs clasped inside their fists for the first 3 to 4 months of life.
Right, they all do that.
Yeah, so it completely masks the underlying pathology until the parents notice the child isn't starting to grasp objects normally.
Give me the key mechanical differentiator. If I'm reading a vignette and the child has a flex thumb, how do I know immediately if it's a trigger thumb or a clasped thumb?
Look strictly at the metacarpophalangeal joint, the MCPJ. A trigger thumb is locked at the interphalangeal joint, but the MCPJ can extend normally.
And in a clasped thumb.
In a clasped thumb, because the whole extensor mechanism is deficient, you will see a profound extension lag of the MCPJ. They simply cannot lift the base of the thumb away from the palm.
And the treatment for clasped thumb, I imagine it's much more complex than a simple pulley release.
Very much so. The primary goal is restoring the thumb's ability to grasp, which means getting it out of the palm. Initial treatment is aggressive splintage and extension for up to 6 months.
Does that usually work?
It is highly effective if you catch it and start before 1 year of age. Surgery is indicated if that splintage fails, or if the child presents older than 2 years with a fixed deformity.
What's the surgical approach?
It's completely tailored to the deficit. You might release the first web space for adduction contractures. You might perform tendon transfers, like routing another tendon to the thumb to reconstruct the deficient extensor mechanism.
And for severe fixed deformities.
You rely on joint fusions to hold the thumb in a functional, opposed position.
You mentioned arthrogryposis as a related condition. Let's zoom out from these isolated digits to the macroscopic level. Paint a vivid clinical picture of an infant born with arthrogryposis multiplex congenita.
Sure.
What is the proposed etiology for these rigid joints, and why is surgical intervention so controversial?
So arthrogryposis comes from the Greek meaning curved joint. It is a devastating syndrome of non-progressive, severe joint contractures that are universally present right at birth. The overarching proposed etiology is fetal akinesia.
Which is just a sheer lack of motion during fetal development, right?
Exactly. Think of the developing fetal joints like a door hinge in a factory. If that hinge is never swung open and closed while the metal is setting, it permanently rusts shut before it ever leaves the factory floor.
Wow, that's a great analogy.
Yeah, the soft tissues, the capsule, the ligaments, they just fibrose and tether the joint permanently.
What causes that lack of fetal movement in the first place?
It traces back to several distinct pathways. The most common are neuromuscular abnormalities, specifically a reduced number of anterior horn cells in the fetal spinal cord, meaning the muscles simply aren't getting the nerve signals to fire.
Are there other causes?
It can also be caused by a physically restricted intrauterine space, severe vascular insufficiency, or maternal illness during pregnancy.
Walk us through the classic physical posture when you examine these infants.
The congenital contractures are usually symmetrical and bilateral. The shoulders are tightly adducted and internally rotated. The elbows are locked in rigid extension, with the forearms fully pronated.
And the hands?
The wrists are sharply flexed, with the hands pulled into extreme ulnar deviation. The digits are uniformly flexed and incredibly stiff. And don't forget, lower limb involvement is a major feature of this syndrome, often presenting with severe club feet.
And the skin. This is a huge visual clue on the board.
Oh, the skin is classic. It is thin, it appears waxy, and there's a profound lack of subcutaneous tissue and muscle wasting. But the most striking feature is the complete absence of joint creases.
Because the creases are formed by movement.
Exactly right. Because the joints never folded in utero, the skin creases never had the chance to form.
So we have a child with stiff, flexed, motionless limbs. What is our actual goal here, and what is the role of the surgeon?
The goals are purely functional. We want to achieve independent function for feeding and perinatal care and maintain whatever bimanual function is possible. Treatment begins on day 1 with dynamic and static splinting, along with aggressive passive stretching by therapists.
And surgery.
Surgical intervention is highly controversial because these joints are incredibly stiff and prone to scarring right back down. You are strictly operating for specific functional deficits, never for aesthetics.
Give me an example.
For example, you might perform recalcitrant elbow contracture releases. If they have no active elbow flexion to bring a hand to their mouth to feed themselves, you might restore it using muscle transfers, like a partial triceps transfer, a pectoralis major transfer, or even a free gracilis muscle flap.
What about the wrists and hands?
At the wrist, you might perform distraction lengthening of the tight volar soft tissues, or a dorsal wedge osteotomy of the radius. Often, the goal of a wrist osteotomy is simply to position the hand so the patient have a flat palm to use a keyboard or a wheelchair joystick.
Makes sense.
And finally, you may need to reconstruct a clasped thumb just to provide a basic pinch grasp against the stiff fingers.
Incredible. Let's pull all of this together. We've traced a line today from highly localized cellular failures, like the manufacturer forgetting to cut the seam in syndactyly apoptosis, all the way to the massive systemic failures of fetal motion in arthrogyroposis, where the hinges rust shut before birth.
It's a huge spectrum.
It really is, and you can see how this entire spectrum of soft tissue differentiation is heavily tested on the FRCS. It demands both microscopic anatomical knowledge and macroscopic functional reasoning.
It absolutely does. You have to be able to seamlessly jump from understanding why a specific web space fails to divide to reconstructing the bimanual function of a child who developed without anterior horn cells. The principles are just totally interconnected.
And that leads to a final thought I want you, the listener, to mull over as you hit the books today. Consider how in pediatric plastic surgery, the absolute hardest part of the discipline isn't necessarily the technical execution of the flaps, the vein grafts, or the tendon releases.
No, it's not.
It's the mastery of timing. From knowing you have the luxury to wait out a trigger thumb until age 3 without joint damage, to perfectly staging a complex syndactyly release to outpace an uneven bone growth vector without destroying the finger's delicate blood supply.
That is the real art of it. If you misjudge the timing, the child's natural postnatal growth vector becomes your enemy, basically pulling your reconstruction apart. If you time it right, growth becomes your greatest asset.
The true surgical skill here lies in manipulating the fourth dimension, time. You aren't just operating on static anatomy, you are operating on a trajectory. All right, that wraps up this deep dive into congenital soft tissue anomalies. We want to hear from you directly, so leave a comment or a question about today's deep dive right now, wherever you're listening. Keep studying, keep refining your knowledge, and we will see you next time.